So I wanted to welcome everyone to Resident Research Day. It is a very special Resident Research Day because it is our last as with Dr. Olson as our chair. And typically he is up here introducing and welcoming everyone, but we figured it would be odd for him to welcome everyone given he is the man of honor today. And will be honored as our Alumni of the Year. Now, technically, he isn't actually an alumni, but as we mentioned at the Academy Alumni Celebration, we wouldn't have any alumni if it wasn't for Randy. We would not have any residents. We would not have a program. And so we felt it was only fitting, and honestly, who else could we honor given Randy will be leaving us here in just a matter of a few short weeks. I'm sure you don't have a giant calendar with and you pull a day off each day in your office, you're definitely not counting down the days, but I'm sure that your wife is. So just a quick word about the impact that Randy has had on resident education. I had the staff just go back and try and look and see how many people have done residency and fellowship over the years here at Moran. The number they came up with is 450, and that's really the only ones that we can actually document with physical documentation. It doesn't include the medical students, the international observers, all of the people that have come through this institution over the last several decades and have benefited from the educational experience that we have here at Moran and the legacy that he is entrusting to all of us to keep his institution going and honor that legacy, I think really has been weighing heavily on me as the residency program director. And I know all of us share a little bit in feeling that burden of making sure that we are honoring him and the legacy that is the Moran Eye Center. On that note, our residents today are going to tell us what they've been up to over the last year, and their projects wouldn't be possible without a really engaged faculty. The things that our residents have managed to accomplish, both with their quality improvement and with their scientific research, it's truly exceptional. This really is one of my favorite days of the year because it is so inspiring. One of the things I constantly brag about for our residents is how every single one of them is so invested in this program and feels really a responsibility to leave it better than they found it. And that is never more clear than it is today. So I wanted to first thank any faculty member who did a research project or a quality improvement project with our residents. We would not be here today without all of you, so thank you. Your time and dedication does not go unnoticed, and we are very, very grateful. And then I'd like to also thank Monica and Bob, who are the meeting chairs, and always put a lot of thought and effort into making sure today runs smoothly and seamlessly, and we could not do this without you. Thank you so much. So big round of applause to them. I'd also like to thank Jordan, who is having a birthday today and is still here and presenting. The reward for all of you, if you stick around till the bitter end, is there is birthday cake, and we will sing. And also Nadim, happy belated birthday by one day. There's cake for you as well. And without further ado, we'll get started.
Good morning. There are a couple of changes in the schedule. It turns out that we're moving Nnana's talk around because he's not here and he won't know. We also have Chase Paulson, who is on consult duty. Consults are lined up, so we're putting him first out of the chute. And turns out that Mubarak is closing an open globe, so that we've moved him a little bit farther down the line. Chase is going to talk to us about gender identity issues. Chase is one of our PGY2 first-year ophthalmology residents. At this point, we asked each of the residents to tell us something about something that we didn't know about them. It turns out that he drew a Komodo dragon when he was in second grade, and apparently this still has had a significant impact on his life. I'd like to see a picture of that at some point. Before I put him up there, the other thing I want to mention, Alan Crandall and I ran this meeting together for years, and I want to just take a second to remember him. Wish he were still here. He'd be quite proud of this group of residents. Rachel, thanks for that wonderful introduction. and you're up. Thanks. Yes, sir.
Good morning, everyone. Thanks for accommodating and allowing me to come first. Without further ado, I was looking through some old knickknacks, and I found this picture of me with my peak bowl cut in second grade, and also my drawing of a Komodo dragon. I was apparently very proud of that at the time, so still am. No financial disclosures for me. And before, I don't want to take up too much time, but I really want to thank everyone for the mentorship, interacting, helping all of us residents through this time, and really helping us build our clinical acumen and trying to address the ophthalmologic need here in the Intermountain West before we head off in our different respective locations. But I had a really good opportunity to work with Ellie Burton, who's at UVA, and Dr. Petty and Dr. Simpson, a couple other people that weren't able to be included on this paper, on looking at gender representation at the AAO conference in a longitudinal basis from 2004 to 2019. Definitely gender equity has been kind of a topic of discussion over the last couple years, really kind of predominantly starting in the 70s, at least that I could see in the literature, especially within medicine, within surgical specialties, and also within ophthalmology. So we'll kind of get into some of the nitty-gritty with this, but you can see on the stats here in the 70s, women comprised only 4% of ophthalmologists. 2021, it increased to about 25 to 30%. Even lately, now that we have over 50% of women matriculating to medical school, there's still a lag in some of the surgical subspecialties. You can see 38% in 2022 of the matched ophthalmology applicants. I'd be remiss not to show a photo of our handsome Dr. Sanchez at the Women in Ophthalmology. He ended up winning the grand prize, beauty products. Just hopefully he's used that well. But kind of looking at the then and now, this picture on the left is from the 1970s at the American Academy of Ophthalmology, and then the best picture they had currently in the last few years was this beautiful rug. But really, there's been a couple studies, one out of Miami looking at women representation at AAO conference from 2018 to 2021. They had slightly higher estimates, closer to 30-35% than I'll kind of discuss today. Another paper looking at 8 of the subspecialty conferences, Nanos, APOS, and the like, showing that women led about 38 to 39% of clinical and scientific presentations. But the overall kind of demographic data we had from the American Academy of Ophthalmology was that the representation was about 24% of presenters in 2021. So despite these advancements, important gender disparities do exist. As of 2020, female ophthalmologists still earned about a significantly lower starting salary in their first year of clinical practice, and in their first 10 years of practice, female ophthalmologists have received less research funding than males after controlling for research productivity. So it's definitely something that still stands as a barrier. And like I mentioned, there's limited data longitudinally, so we wanted to look at this range from 2004 to 2019. We fastidiously combed through the AAO website and archives that they do have. It was extremely tedious and uncomfortable, and many people phased out because it was so terrible. But we looked through, everyone divided up. We picked, divide things up into clinically and surgically, and then within that, those 9 ophthalmologic subspecialties. We excluded posters because those are not as visible. We didn't feel like it was as important. So any session or session leader, speaker, panelist, committee member awardee was listed as a presenter. And then in terms of defining gender, this isn't perfect, obviously, but we looked up a picture of the physician, which definitely took a lot of time. And if there was no picture available, then we used a gender API tool. It's like a website that you put in the name, and it's like, this is the most likely gender. So once again, fraught with imperfection, but kind of the best we had to work with. So our results, we had 20,000 presenters over this time. There was 13% female representation in 2004 and 29% in 2019, so growing. The most common specialists were comprehensive cornea and retina. The greatest increase was oncology with combined surgical and clinical. And then oculoplastics and peds were surgically the greatest increase. And then the least amount of increase was in glaucoma and neuroop. So a couple diagrams coming up in the next couple slides. These first two are the clinical. I will admit the colors are kind of hard, but if you look from left to right, it goes comp, cornea, glaucoma, neuro, oculoplastics, and then the kind of faint bluish colors will go, oncology, peds, retina, uveitis. You can see that clinically, oculoplastics had kind of a good bump, and also for pediatrics. Our data in 2016 was a little bit limited and sparse on the website, so there is quite a bit of fluctuation you'll see in 2016, but we kind of excluded that we looked at it, but obviously took in a grain of salt that it was lower numbers, so less reliable. Here's the overall trend in clinical, starting in the low teens and then bumping up to close to 30% is that black line with the circles. And then you can see how oculoplastics had this initial dip, but kind of slowly grew over time. Surgically, once again, a little bit harder to see here, but pediatrics was starting higher and then kind of tapered down a little bit. Plastics had the biggest swing if we include 2019, but kind of notably, most things stayed more or less the same as over these Q3 year intervals. And then here's the surgical subspecialty, once again climbing from the low teens to about 30%, and you can see kind of the largest increase there in uveitis in 2016. But pediatrics started higher and then kind of tapered down a little bit over time, which was quite interesting. So overall, female representation among presenters increased by 16% over this about 15-year period. Kind of difficult to comment on the representation overall. We tried reaching out pretty extensively to the AAO to get the exact breakdown of male and females practicing ophthalmology and at least registered through the AAO. And the data was very sparse, unfortunately, for the years we picked. Maybe we should have picked different years, but we thought about that after. We did a lot of work. Our findings were a little bit less than before. The paper from Miami reported it in the higher 30s. They had a little bit different methods. Obviously, ours was a longer time period and had a little bit more data, and so we think ours might be a little bit more accurate. But overall, a little bit of fluctuation in some of the subspecialties, but overall kind of getting a little bit closer to maybe more equal representation. Notably, the AMA estimated about 29% of ophthalmology department faculty and 16% of ophthalmologists with direct patient care were female in 2005. And then these numbers increasing to 35 and 23%. Obviously, this is a very important matter as with a lack of appropriate role models can be described as a barrier to women in academic medicine and can have quite lasting impacts therein. So the biggest strength of our data set was it looked at 15 years. Quite a few limitations. We had binary gender assignment, and we can't really generalize to other conferences. It was going to be too much work for the methods that we described. And we can't fully estimate to the overall population. So in this niche subset of AAO presenters, we did have an increase over time. And definitely open to any future thoughts that come along with this. Special thanks to my mentors and the other residents and people involved in this, and happy to take questions.
We're going to move on to the PGY4 group. Jordan Desautels is going to be up next. Jordan is on his way to a cornea fellowship, OHSU, next year. We're proud of him and wish him well. Jordan's going to talk to us about vector analysis in predicting astigmatic correction with toric IOLs. And his interesting fact, when he was younger, he was interested in seeing how many mosquito bites one could acquire, and on a camping trip in Hawaii, sat for an extended period with no shirt on, and it was reported that he acquired over 300 mosquito bites. Why he did that, I'm not sure, but it was probably the beginning of his research career. Jordan.
Yeah, I'm wired. I got the lapel mic just because this is a little short. If you can all hear me, is good? Perfect. So this is Mount Moran, across from Lake Jackson, where we get our namesake. So, but I'll be talking a little bit about an early project that I actually just recently started with Dr. Savage from some of Dr. Mifflin's data. And right now we're still kind of building the data set, but I'll go over some of the preliminary results. And essentially we're looking at astigmatic outcomes for toric IOLs. And I want to talk a little bit about the vector analysis that goes into that and present some of that data. So I'll just start off by, we all put in toric IOLs, and unlike with corneal refractive surgery, where there's fewer variables, there's a lot of variables that go into essentially gauging toric IOL outcomes. And so first and foremost, I'll just introduce some of the terminology that goes into doing so. And then I want to talk a little bit about vector-based analyses for looking at toric IOLs in a few different capacities. One is just presenting how we kind of look at astigmatic error. And then the other will be talking about the next phase of our project, which is actually some MATLAB software that we're writing to do Alpen's vector analysis. And essentially what this project does is, when we all put in toric IOLs, we typically just take our anterior Ks off the IOL master and plug those into whatever IOL prediction formulas we use, whether that's Barrett or an Alcon platform or any of the other proprietary calculators. And we kind of go off those values, but we have all of these modalities available to us in clinic. We have our IOL master, we have our Pentacam, we also have our Atlas. So we really wanted to see, is there any difference in prediction error for the final outcome of our toric IOLs from using any of these other different modalities of keratometric analysis? So when you're doing corneal refractive surgery and you're looking at your outcomes, essentially the only two variables that you have to look at are what is your change in manifest refraction and what is your change in the anterior corneal curvature, because those ablations or changes are all just applied to the anterior surface. But when you're talking about doing refractive surgery for toric IOLs, the number of variables expands massively because your manifest refractive outcome is essentially a composite of the anterior corneal curvature, also the posterior corneal curvature because you're making full thickness incisions, but also IOL alignment and several facets of IOL alignment being where you center that IOL, how you rotate it into place, so what's the final toricity at the corneal plane, and then even the tilt of that IOL. And tilt actually becomes astigmatically important for even non-toric IOLs as well, because it can induce astigmatism. So this is a really nice 2018 paper that essentially just tries to standardize the terminology that we all use to talk about toric IOL outcomes, and we use this as a framework for our analysis as well. They introduce a lot of standardized terminology, and I'll just kind of go over some of the important ones for our analysis. First of all, you have your predicted surgically induced astigmatism, or SIA. This is essentially what you're getting out of your Barrett toric calculator or whatever other calculator you may be using. This is what you think you're going to get. The actual surgically induced astigmatism is what you actually get. And it's a composite of many factors. And then the prediction error essentially is just the difference between what you thought you were going to get and what you actually got. And there are several variables that are kind of difficult to analyze for actual SIA. So they break it down a little bit more into the ones that are actually measurable. So the surgically induced astigmatism of the cornea, which is SIA cornea, and then that of the induced by the IOL itself, which is SIA IOL, and those two variables together make up the total surgically induced astigmatism. Then, when you look at the actual postoperative refractive astigmatic prediction error, this actually has to be a vector quantity, so it actually has to take into account the magnitude and direction of the toric IOL that was implanted. So for our study, right now, we have 16 eyes, 5 right and 11 left eyes. They're all imaged preoperatively with the IOL master, Pentacam, and Atlas at their preoperative visit. And all these patients got a Johnson & Johnson ZCU platform lens from 1.5 to 6 diopters in toric power. And they were all implanted by the same surgeon using a temporal incision that had an assumed induced corneal astigmatism of 0.1 diopters at 0 or 180 degrees. And then all of the postoperative predicted refractive astigmatisms were generated using the Barrett Universal Toric Calculator, and we inputted several different keratometric values, and those were from the IOL master, the IOL master TKs, also the Pentacam SIM-Ks, Pentacam TK, Atlas K, and then also a combined index, which is essentially an average of all of these values. And then we present all of these astigmatic errors as double angle vector plots. So this is just kind of introducing the double angle vector plot and what you get. And by doubling all of your angles that you're using for your toric IOLs, it makes things a little bit more convenient because you essentially see that all of your against the rule astigmatism cases are kind of in that quadrant on the right, and then all of your with the rule are on that quadrant on the left, and then the vertical two quadrants are your oblique astigmatism. And then it's really nice because when you essentially present your data, you can calculate a centroid for all the vector points and see essentially where that centroid lies and the confidence interval of that centroid. So this is just what we all know. If you put in a toric IOL, this is just our data set at preoperative visit where all their astigmatism lied, and then the total group at 1 month, and you see that centroid locks nicely pretty close to 0 there. So when you look at all of the different modalities that we have, you know, I think not surprisingly, but encouragingly, they're all actually very, very accurate. And I think our intuition to use IOL Master K as just the anterior Ks is correct because the mean prediction error for the IOL Master Ks actually ends up being lower than any other modality, both in terms of the mean prediction error, the mean absolute error, and then also the centroid error. And so we can see that here for both our IOL-K, which is again, just the anterior Ks, and we see that prediction error is the lowest for our torics, but the other one that actually came out well as the IOL, the overall index where we average the IOL-Ks, the total Ks, the Pentacam SIM-K, and the Atlas K. And these are just all of our different cases plotted out. So kind of our next step in this is, you know, there's been some research that essentially has looked at centroid values after toric IOL implantation and essentially has shown that one of the best predictors is actually taking a vector sum of the anterior and posterior corneal curvature. So right now we just kind of got our MATLAB code up and running, but it essentially represents the anterior corneal curvature as a vector, which you see in blue there, the posterior corneal curvature as a vector, which you see in red, and then it computes a net K vector from all of that, and then we'll be running that back through the Barrett toric calculator again and getting data from that. So essentially, the biggest limitation of this project is that we don't have like photos of our IOLs at like post-op month 1, so we don't know that they landed exactly on the axis that we intended them to be on. So that's just kind of one of our major assumptions. But that's all I have for this morning. And thank you to Daniel Savage, who has given us all so many projects this year. And I'll take any questions.
We're going to move on to our next PGY4, and we're going to put up a video from Nnana Amakiri, who is at present, his interesting thing about him is that he's on an airplane right now on his way to Tanzania, and it turns out that his favorite flavor of ice cream is vanilla. I think I share that with him. I'm not sure it's that unusual, but I haven't thought it was unusual, but there we are. And by the way, this is on Zoom. Chat is not working, but it is being broadcast the same way we broadcast Grand Rounds so that anyone who is working in an outlying institution can watch what's going on here.
Hi, everyone. My name is Nnana Amakiri. I'm one of the fourth-year residents here at the Moran Eye Center, and I'm excited to share with you a tool I've been building to solve a problem that almost every student and resident faces, balancing study goals with a hectic, unpredictable schedule. That tool is called Pupil Planner, and the title of my presentation today is the same as last year, Eyes on the Future, Optimizing Learning with an Ophthalmology Study Planner, Part 2. I was kayaking a couple months ago, and the journey we took felt very similar to the journey I took in the development of the study planner. It was long and arduous, and the path was somewhat unclear. I waited weeks to get engineers to help, only for them to go silent for months. Safe to say, the amount of hours I ultimately put into this project was unexpected. And with a lot of excitement, I look forward to showing you what this ultimately looked like. Last year, I talked to you about the main motivations for this project, including the difficulties of studying. A lot of this is listed again on this slide, and I won't really hash it out again. In residency, especially in fields like ophthalmology, our schedules are anything but consistent. You might have 12 hours to study one day and none the next. Traditional planners assume you can treat every day the same, and the world really just doesn't work like that. In a pre-implementation survey, we had results from about 20 residents at 3 institutions. It showed that only 56% of these residents studied about 1 to 5 hours per week for the OCAP exam. Of those that did, 89% did not use formal tools to organize their study schedules. 56% found it at least somewhat difficult to adapt their schedules to ongoing life challenges, and 56% were somewhat dissatisfied with their current study schedules. Here's a rough timeline of how our team has tackled this project. After identifying the need and developing a study planner, we distributed pre-implementation surveys and analyzed their results. We are now distributing this planner and the goal of follow-up surveys in the future. We visualized the study planner to be impactful by giving residents flexibility with their availability, an opportunity to optimize the tasks that they would like to choose and confidently get through them. And we envisioned opportunities for iterative feedback and improvement through feedback surveys over time. This app, Pupil Planner, is a smart, adaptive study planning app built with learners in mind. It takes your test date, your study goals, like the number of questions you want to complete or pages you want to read, and automatically creates a daily plan that adjusts to your actual life. All right, let's get to it. So I'm going to show you how the app functions on my phone through a screen recording here. First, we're just going to peruse around in this study tab. When I click on basic optics, it's going to show me all of the PowerPoints, the AO PowerPoints listed here. You'll see a time on the bottom left, which is just the amount of time it took me to just read over the slides. And also gives you a number of slides as well. When you click on something, it just updates this orange bar progress meter there. Next up, we're going to go to the More section and then move over to test date. So you can manually input exactly when your test date is. And you can also input exactly how many questions you want to do, and I think opto questions are around 3,000 to 4,000 questions, so I set that there. It'll show you your daily target for questions. I'm going to move back and actually move to the Settings tab now. I can actually send a push notification, and I'm going to change that to 6 p.m. So after work, I can know exactly what I need to do coming home. Next up, we're going to go back to the More section. I'm going to just show you the Progress tab, just kind of a general overview tab here. It shows you the recent text you've completed and just general percentage of where you're at. The Study Availability tab just allows you to personalize your study schedule every week, and you just need to update the schedule on the bottom. Next up, we're going to move over to the study schedule. And so this is just a general overview as well. It shows you exactly what things are scheduled for a given day, including the number of pages you need to read on the bottom of the topics. On Fridays, I left that as a no study day. And so you'll see as I peruse over there, there won't be any topics listed for that given day. Now we're going to move over to the Reading Materials tab. Here you can manually input exactly what reading you want to do. You put the title, you put the number of pages, and you set the target completion date here. So I'm going to walk you through how to do that. You can also delete it. And so if you're like, hey, you know what, I don't want to study this Pupil Planner guide, just slide to the left and you can delete it just like any other iOS function. On the study mode area, it shows you that you can arrange exactly how you want the PowerPoints to come up for you. And so online, it's listed under various topics, and so you can set it by said topics or first of each slide. In the Today section, this is probably the most important section. It shows you exactly what is scheduled, the number of pages, the amount of time. You just need to click on the circles to update that. For reading specifically, you type in exactly how many pages you read that day. Same thing for the questions, and then it'll update the entire database accordingly. So you'll see here how the reading materials, I put 20 in, so 20 pages for the BCSC was updated there. So why does it matter? I think ultimately pupil planner is about reducing cognitive load. Instead of just wasting mental energy on how to divide your study time, this app helps you focus on learning. It's built for real life, not ideal schedules. The adaptability feature is perhaps the most important feature and really the main motivation for the creation of Pupil Planner. So going to the future plans idea, I'm currently prototyping and testing the core engine of this app, and I'd love feedback from fellow learners to help shape it. If you're interested in trying it out or collaborating or know someone who is interested, please reach out. I'm recording this a couple of months before Resident Research Day, so it may actually already be on the App Store, but definitely publication is the next current plan. After that, I do hope to have some performance analytics to see where users are struggling. And of course, the post-implementation surveys are going to be huge for really improving this app over time. I think links to resources in the future on a desktop version of this application would be super useful. So maybe clicking on a link that navigates you to the study PowerPoint would be really, really nice. And lastly, I would like to acknowledge a lot of the help that came along the way during this project. Clement Anozi and Hannah Yu coming from UTMB in Houston, Candace Winterton, a medical student here in Utah, Ivan Cardenas, Rachel Simpson, and Dr. Sravanti Vegutta. Thanks so much, everyone, for your time and for your attention. This is not a picture of Tanzania, but I do hope to have some photos of Tanzania to share with you all soon. This is Aspen at a wedding I was at a year and a half ago. And I'm so excited to watch some of your presentations online here in the near future. Thank you again.
Ashley Polski is our next PGY4. Ashley, she's going to stick around here and do a glaucoma fellowship next year at Moran, and we're grateful that we get another year with you here. She's going to talk to us about the massive data overload that you can encounter in trying to make sense of glaucoma patients.
All right, thank you. I'm excited to be here at my last resident research day as a resident. Over the past almost 4 years now, I've worked with Dr. Stagg to study different aspects of glaucoma care. And most recently, we've been using a large database to try to better understand different factors that impact clinical decision-making in glaucoma. And today I'm kind of continuing along that theme by talking about the data burden associated with glaucoma care and also discussing the potential impact of high cognitive burden on clinical decision-making in glaucoma. I have no conflicts of interest. And here's just a brief outline of what I'll be talking about today. So as many of you are unfortunately very aware, physicians working in the age of electronic health records are frequently tasked with accurately and efficiently assessing large amounts of clinical data to care for their patients. With vast quantities of patient information readily available online and even transferable between medical centers, information overload is becoming an increasingly common and well-recognized issue for modern clinicians. Consequently, there is growing interest in developing user-focused clinical decision support tools to help mitigate the impact of this data burden in clinical settings. In glaucoma care specifically, providers are often required to synthesize numerous different types of clinical data over time in order to appropriately diagnose, risk stratify, and treat their patients. And although this issue of information overload is becoming better recognized within the medical community, there's actually very limited work examining the data burden associated with glaucoma care. There was a recent UK database study that evaluated the cost burden associated with glaucoma and included a quantification of a few basic glaucoma tests, but that study was limited to a pretty small 5 index year period, and as we know, glaucoma patients are often followed and accumulate clinical data for much longer than 5 years due to the chronic progressive nature of their condition. And so we felt that having a better understanding of the cumulative scale of data burden over time could potentially be more representative of what the glaucoma provider actually experiences. and could potentially be useful for developing future strategies to combat this issue of information overload. So the aim of our study was to better quantify the cumulative clinical data burden associated with longitudinal glaucoma care. To accomplish this, we retrospectively reviewed electronic health record data from the Site Outcomes Research Collaborative, or SOURCE, which is a multi-center ophthalmology data repository containing de-identified records from millions of patients, as well as associated diagnostic and procedural codes. Specifically, we queried the database between 2009 and 2022 to identify all patients with a diagnosis of glaucoma who were seen by an eye care provider in 2021 and at least 2 years prior. And we included that 2-year minimum enrollment period mainly to ensure that we were including glaucoma patients who were receiving ongoing eye care rather than just single visit consultations. Patients were then excluded from the study if they were not seen by an eye care provider, if they had no prior IOP measurements on record, or if they were enrolled in the database for less than 2 years. We then counted the total number of glaucoma-relevant clinical data points for each patient, including IOP measurements, visual field tests, RNFL OCTs, prior glaucoma drops or lasers or surgeries, the number of previous eye care providers seen, and the number of glaucoma-relevant comorbidities based on the AAO preferred practice guidelines for glaucoma. So essentially, we were counting up all of the different clinical data points that a glaucoma provider would have to assess and interpret in order to make treatment decisions. We also determined the number of glaucoma patients per provider within a 1-year period, just to give us a better understanding of the cumulative scale of these clinical data points for individual eye care providers. A total of 21,448 glaucoma patients across 11 different academic eye centers were included in the study. Patients had a median enrollment period of 2,641 days and a median age of 76 years. About 58% of patients were female, and nearly 80% of patients were enrolled in the database for 6 or more years. Throughout the study period, glaucoma patients were seen by 11,702 unique eye care providers, and for about 5% of these providers, glaucoma patients comprised a fairly large proportion, over 30% of their clinical practice. In the year 2021 alone, providers saw a median of 31 unique glaucoma patients each, although as you can see, this number varied widely, with an outlier provider seeing as many as 1,800 different glaucoma patients that year. Here's a table summarizing the overall number of glaucoma-relevant clinical data points per patient, including the median, interquartile range, and range of values for each patient, for each category. And again, this represents the total number of data points that were on record at the time of the patient's most recent clinic visit in 2021. Patients underwent a median of 27 IOP measurements, 6 visual field tests, and 7 RNFL OCTs throughout the study period. But there was a wide range of values, as you can see in the minimum and maximum columns on the right. For example, one patient had as many as 352 prior IOP measurements on record. Yeah, whoa. One thing that surprised us was how many patients had no interventional glaucoma procedures such as SLT or surgery within the study period. And it's definitely possible that some of these patients had received surgical treatments prior to their enrollment in this database, and so perhaps those procedures were just not captured within the source data. Also, some interventional glaucoma techniques, such as like first-line SLT or certain MIGS devices, are relatively new in the glaucoma treatment landscape, and so it's possible that we would see higher numbers in that glaucoma procedures category if we were to repeat this analysis for more recent years. Another thing that I just wanted to point out is that one patient had seen up to 47 different eye care providers in the past, and I know that many of you are really familiar with how complicated that can become when a patient has had many different providers or different treatments that you have to kind of keep track of moving forward. We also stratified these data by years of enrollment, grouping patients into either 2 to 5 years of enrollment, 6 to 8 years, or 9+ years. And I know that this is way too big of a table to really read and take in a presentation, but if you're interested in looking at specific values for each of these categories, it's on my ARVO poster that's out in the lobby. In general, we found that, as expected, patients with 6 to 8 years of enrollment had higher volumes of recorded clinical data compared to patients with only 2 to 5 years of recorded follow-up. There were only 8 patients that had 9+ years of recorded follow-up, since this is a relatively new database, and so we really couldn't look at data burden trends in that small group. As I mentioned earlier, there was substantial variability in the amount of data burden per patient, even among patients with similar enrollment periods, and I suspect that at least some of that variability can be attributed to both patient and provider differences, such as individual provider training and experience, testing availability, patient compliance, and disease severity. Despite this variability, however, over 98% of all the patients in our study had more than 7 glaucoma-relevant clinical data points on record at the time of their most recent clinic visit. And we'll talk a little bit more in a bit about why that number 7 is important. Overall, our findings highlight the complexity of longitudinal glaucoma management, demonstrating that glaucoma providers have to evaluate high volumes of data in order to make treatment decisions. And there are other potentially relevant clinical factors that were not available in the source database that could still be contributing to the overall data burden that providers experience, such as home perimetry testing and home tonometry findings. And so it's very likely that the true extent of data burden in glaucoma care is even more substantial than what our analysis can fully demonstrate. Unfortunately, humans have a limited capacity to process clinical data and deal with complex problems associated with clinical decision-making. Multiple previous studies have suggested that human working memory can only handle about 7 ± 2 items of information at a time before our processing abilities start to break down. And if you recall, over 98% of all the patients in our study had more than 7 glaucoma-relevant data points on file. So really, our study suggests that glaucoma providers are frequently having to deal with volumes of data that exceed what is considered standard human processing capacity. Additionally, the prevalence of glaucoma is expected to substantially increase in the coming decades, with estimates suggesting that nearly 112 million people worldwide will be living with glaucoma by 2040. And this expanding patient population will likely only further compound this issue of information overload for glaucoma providers. Numerous inpatient and outpatient studies have suggested that information overload and increased cognitive burden can contribute to impaired clinical decision-making, reduced efficiency, and even provider burnout, which is why many researchers, including Dr. Stagg, are working towards developing clinical decision support tools that could hopefully help streamline data interpretation and improve the overall efficiency and accuracy of patient care. And this figure is actually an example of a really cool glaucoma clinical decision support system that Dr. Stagg has been developing that essentially integrates prior patient data with provider inputs to determine the appropriate patient-specific interval for visual field testing. And there are examples really throughout all of ophthalmology of people working towards developing clinical decision support tools like this. So in summary, our study underscores the large volume of data and growing clinical complexity associated with longitudinal glaucoma care. And it also emphasizes the need for improved strategies and clinical decision support tools to help providers manage this data burden and mitigate the issue of information overload. Here's some relevant references. And thank you to all of the collaborators shown here, especially Dr. Stagg, who's been a really awesome mentor over the past 4 years. I also wanted to say a big thank you to the ARCS Foundation and their support, which has helped fund my publications and projects throughout residency. Thank you.
So we will continue with our PGY3 residents, but actually for me it's very important to mention Megan Johnson here. She did actually almost all the work to organize this resident research day. And so she made the program, she actually collected the information about the residents, and she made it very easy for Bob Hoffman and I to be the moderators here. So Megan, thank you so much. Incredible work. Thank you. And then one other thing I would like to mention, coming back to Jay's presentation, I wanted to say that I'm extremely grateful to be in an institution where we have incredible female role models. So Judith Warner, Kathleen Degree, and of course many others who are incredible for us women to see how you can succeed in ophthalmology. So Dr. Olson, thank you so much for making this possible and having this environment here. Thank you. Okay, another upcoming role model. I'm really impressed. So Ayesha Patil, she has a black belt in Taekwondo, so watch out. And she will actually present to us on Idiopathic Intracranial Hypertension Family Tree Edition.
All right, thanks Dr. Fleckenstein for that introduction. I've always had an interest in kind of epidemiology research, so I'm excited to present this year on a IAH project that I've been working on with my female role models, Dr. Degree and Dr. Warner. So here's a basic roadmap of the presentation. I'll be spending most of the time on the methodology of the project, which is sort of the unique part of this project I've been working on. So just some background on IAH. It is characterized as elevated intracranial pressure of uncertain etiology. It was first described by Foley in 1954, coined as benign intracranial hypertension, and then later on in 1986, Courbet coined it as idiopathic intracranial hypertension. And you might also know it as pseudotumor cerebri syndrome, which was described by Johnson in 1991. But essentially it's primary, meaning idiopathic, so it doesn't include secondary causes like CVSTs or venous sinus thromboses. The incidence for IAH is estimated to be about 1 in 100,000 in the general US population, or 10 to 20 in 100,000 in obese individuals, which is as common as MS, but we know that the general population doesn't know of IAH as much as they may know of MS. And it's most commonly seen in obese women of childbearing age. So this is a BMI ranging from 30 to 39, and the average age of onset is 29 years. It's diagnosed using the modified Dandy criteria, and all of the criteria must be met for a diagnosis. So you have to have classic signs and symptoms of IAH, that's the headache, nausea, vomiting, visual changes. You can't have any localized neurologic features except maybe a cranial nerve 6 palsy, and you should have elevated CSF pressure on a lumbar puncture. And there shouldn't be any other findings to just explain the increased ICP on neuroimaging. So classically, you may see bilateral disc edema, and then on the MRI image there, you can see dilated optic nerve sheets that look more tortuous, as well as posterior flattening of the globes. And looking at the genetics of IAH, other people have also asked this question, is there a genetic component? And this was first looked at by James Courbet in 2008. He looked at 237 family members, and 27 patients came exclusively from 11 families. And within those families, 85% of those family members were obese. This was more than what was expected. And then later on in 2014, one of the big research groups looking at IAH, the Nordic IHTT, the treatment trial group, also looked at this using a large prospective cohort of untreated patients, of which 98% were women, and this total patient group was 165 patients. 5% of that group had a family history of IAH. This same group then went on to do a genome-wide association study in 2019. They looked at chromosomal DNA for 95 patients and came across 3 single nucleotide polymorphisms that were identified among thousands and thousands of markers. But unfortunately, the study size was limited, so they weren't able to draw any significant associations there. And you might be wondering, is obesity a confounding factor in evaluating the genetics of IAH? We do know it is associated, and there was actually a very interesting study done in 2011 that looked at 606 morbidly obese patients, so an average BMI of 47 in this population group. And that was in an obesity clinic, and they looked at optic nerves using optic nerve photographs as well as exams, and only 3 of those patients met the modified Dandy criteria. So there's likely a component of environmental and genetic factors at play. So the study purpose for this was providing a unique method of analysis in identifying familial predispositions in IAH. We used a few different data sources. We used the Utah Population Database, which is a really amazing database, over 11 million individuals and pedigrees dating back to the 18th century. We also used data science sources, which includes all patients with a record of at the University of Utah health facilities. And then we used 2 special databases, the REDCap database, which has been curated by our neuro-ophthalmology team and has patients seen in clinic that have been diagnosed with IAH. And then we have the GNOC database, which has, similar to the REDCap database, patients that have been evaluated in our clinic setting. And so looking at inclusion and exclusion criteria for the 2 bigger databases, the Utah Population Database and the data science sources, we used ICD-9 and 10 coding for patients over the age of 7 diagnosed with IAH. And the exclusion criteria for them was anyone with an obstructive hydrocephalus diagnosis within the first month of their IAH diagnosis was left out, and then you couldn't have a neoplasm related to your IAH diagnosis time. The REDCap and GNOC databases had much more stringent inclusion criteria, mostly looking at probable, possible, and definite IAH diagnoses. So this was really the interesting methodology of this study project. We used something called familial standardized incidence ratio, which came out of the Huntsman Cancer Institute. It's used primarily in cancer epidemiology research, but it essentially is used to identify individuals whose extended family has a greater incidence of a phenotype than what would be expected in the general population. And so the population incidence rate in Utah was calculated using all of the Utah residents in UPDB from 1988 to 2023, and that was stratified by sex and age. And FSIR is really unique because you can also then use this to sort of identify an individual in like a family pedigree tree, identify their risk of developing a disease based on how present that is in their own family pedigree. So we use this to identify high-risk pedigrees. It calculated 15,000 different pedigree founders having at least 2 descendants affected by IAH. And then within that, we found 10 extended pedigrees with an excess IAH incidence. So among these 10 pedigrees, we have an FSIR ranging from 1.87 to 4.91, and again, very significant p-values. We then went on to ask ourselves, how accurate are our pedigrees? So a detailed chart review was performed by our trained neuro-ophthalmologist to confirm an IAH diagnosis. And of 111 patients whose health records were available for review, 51% had a confirmed true diagnosis of IAH. So compared to 25 other large database studies, this is within the diagnostic accuracy of what you can get from large databases, which is 50 to 97.8%. The average age of the patients included here was 42.7 years, but this was not the average age at diagnosis of IAH, and then women accounted for 86% of the study group. As far as kind of strengths of the study, this is really the largest population database study that's spanning multiple generations, and being able to tap into the pedigree data is very helpful at looking at familial inheritance of diseases. I do think this method could be even more useful over the next few decades as more and more patients are actually in our electronic health records. We may be able to generate more pedigree data that way. And then each pedigree contained at least 2 confirmed cases of IAH, and all of our cases were reviewed by our neuro-ophthalmologists. The main weaknesses, of course, with a lot of large database studies is ICD-9 and 10 coding can be inaccurate, and so, there were several patients who were misclassified. Things like pulmonary hypertension somehow came up as IAH, or obstructive sleep apnea, ocular hypertension, and our diagnostic coding accuracy isn't as high, unfortunately. But what will be interesting is to then go back and actually see which of the pedigree patients have confirmed IAH, and then look at those pedigrees specifically to see if they still have an important FSIR or significant FSIR. There's also someone in our research group who's going to be doing a follow-up genetic study using whole exome sequencing to look at the genetics of IAH. And eventually, hopefully, we can get this published. Here are my references. I just want to say thank you to Dr. Warner and Dr. DeGree for being such great female role models on this project and just in the neuro-ophthalmology clinic. And then thank you to our amazing biostatisticians who helped with this. Happy to take any questions or comments.
So our next speaker is George Sanchez. And one fact about him is that he worked 3 different jobs, once at the same time, actually, during college. And this was making sandwiches at a cafe, soccer referee, and concession stand worker. I just had to ask Bob Hoffman what that is. Now I got it. Okay, so George will speak today about retinoblastoma in the Intermountain West.
Thanks, Dr. Fleckenstein, for the very kind introduction. So yeah, I look very fondly back at that time in college when I was trying to juggle so many things, and made me just develop a really strong work ethic. And so today I'm going to be talking about retinoblastoma here in the Intermountain West, specifically looking at our patients at the Moran that we've seen since 2017. And so I have no financial disclosures. It's kind of a layout for today's talk with we'll just get right into it with some case examples and a brief overview of the genetics of retinoblastoma. And so retinoblastoma, as we all know, 98% of cases are due to inactivation of the RB gene on chromosome 13. That other 2% is more so related to somatic amplification of the oncogene MYCN. The understanding of retinoblastoma really centers on the 2-hit hypothesis, where you lose one allele followed by a second hit thereafter. And the cell of origin is the cone photoreceptor precursor. And so the classic teaching is that germline retinoblastoma or hereditary retinoblastoma accounts for 40% of all cases, whereas a non-hereditary form or the somatic form accounts for 60% of all cases. And at the age of diagnosis, bilateral RB tends to be about a year old, whereas unilateral tends to be 2 years old. And that's just the classic kind of teaching. Here's more of a graphic representation of that. So for the hereditary or germline form, 80% of those cases actually are de novo without a positive family history in the past. And as far as so this graphic representation shows the somatic mutation. So we see here an egg cell and a germ cell coming together form the zygote, which thereby undergoes cell division. Somewhere along the line, a mutation occurs in one of the 2 alleles. That's the first hit, followed by a second hit as more cell division events occur. And so that ends up leading to the retinoblastoma. In contrast, a germline mutation is when either the egg cell or the sperm cell has that mutation and comes together, forms the zygote. The zygote already has one of the two hits in the two-hit hypothesis. Cell division occurs, and a second mutation happens, thereby leading to retinoblastoma. And this is just a case example of a 2-month-old girl that we saw here at the Moran. She actually had a family history of retinoblastoma. Her maternal grandfather had been enucleated and underwent radiation therapy. Her mother had retinoblastoma and underwent chemotherapy. She came in at 2 months old with bilateral RB, as you can see here on the fundus photos, as well as the macro CT. She ended up undergoing 10 treatments of laser therapy on the right eye and 5 treatments of laser therapy on the left, with intraarterial chemo done down the line in the right eye. And so she came back positive for a germline mutation consistent with a positive family history. In contrast, we have case 2 here, a 6-year-old boy, and he presented to us with a pseudohypopyon in the right eye, a staphyloma and scleromalacia. He underwent enucleation of the right eye due to this anterior infiltrative retinoblastoma, and then underwent 5 sessions of systemic chemotherapy. He was last seen by us in March of earlier this year, had a EUA done of the left eye, no signs of malignancy, and an MRI that was negative. And so he had a somatic mutation, so non-germline. And then this leads me to my next kind of point in my talk. So the retinoblastoma on a global scale. And so this is how I got involved in the project. Dr. Hansen is part of the Global Retinoblastoma Study Group. And the study group that was established back in 2020 was looking at outcomes, patient presentation, as well as demographics for the year 2024. And so this study group was established by Dr. Fabian out of Israel back in 2020. It spans over 140 countries, 450 centers worldwide, and they've come out with major works to date spanning a lot of high impact factor journals like JAMA Oncology, Eye, The Lancet, so on and so forth. One of these studies that the study group came out with looked at outcomes related to retinoblastoma on a global scale, dividing patients by the country of origin, looking at income level of these countries. And so when dividing up these over 4,000 patients by income level of their country of origin, they saw there was a stark contrast in outcomes, where low and middle income countries tend to have worse outcomes, diagnosis later on in life at 30 months old on average. 49% tend to have extraocular disease, and 18% tend to have metastasis. In contrast, a high-income country have earlier diagnosis, less likelihood of extraocular disease, and less likelihood of metastasis. And so this is kind of based on the World Population Prospects publication by the United Nations, looking at high-income countries, places like Germany, Poland, the United States, Spain, so on and so forth, in contrast to low-income countries, places like Guinea and Rwanda, South Sudan, so on and so forth. And so kind of leading to the next sort of major publication that the study group came out with was looking at extraocular tumor spread as well as 3-year survival rate for patients with retinoblastoma based on country of origin. And so they divided up these over 4,000 patients and looked at both of these things. The 3-year survival rate was just a very surprising and just surprising sort of result that kind of tells us that the income level really does dictate how well patients do. So high income level countries, their 3-year survival rate for their patients, over 99% of patients survive at 3 years out, whereas low income level countries, less than 60% of patients end up surviving 3 years out from their diagnosis. So ultimately, children from low income level countries are 16 times more likely to die from retinoblastoma compared to those from high income level countries within 3 years of their diagnosis. And so this is kind of how I got involved. The Global Retinoblastoma Study Group wanted to look at patients from the year 2024. And so I looked at the 7 patients that presented to us last year with retinoblastoma at the Moran, including and as well as the other patients who we have up through 2017, a total of 29 patients. And so our patients here in the Intermountain West, they come from really all over, 20 in the state of Utah, but another 9 from the surrounding states. Places like Cedar City, Las Vegas, Deer Lodge, Montana, Etna, Wyoming. On average, the one-way travel time for our patients tends to be 2.5 hours on a typical weekday at 8 a.m. So they're really coming from very large distances away. The overall demographics of our patients, so really an even split, male and female. On average, 14 months old is when our patients get diagnosed. That's really in line with high-income level countries. The youngest that we diagnosed was 5 days old, but the oldest was a patient who came in with a prior history of retinoblastoma that was treated, and so he came in at 10 years old, just was treated outside of the country. As far as laterality, really an even split between right, left, and bilateral. And then when it comes to presentation, more often than not, our patients come in with leukocoria and strab, but other things like visual acuity decrease and older patients that are able to give a reliable visual acuity exam and positive screening for retinoblastoma if a patient does have a family history or other reasons our patients came in. And then as far as the genetics, so pretty much an even split between somatic and germline mutations, a little bit more common to see germline in our patients. And then per the retinoblastoma study group, they like to stage it based on TNM, and so T1 through T4. And just to give a very brief overview of this, T1 includes things like how much subretinal fluid there is from the base of the tumor, and then taking into account where that tumor is relative to the disc and the fovea. T2 includes things like retinal detachment, vitreous seeding, subretinal seeding of the tumor. Moving on to T3, things like raised intraocular pressure, invasion of the pars plana ancillary body, kind of like our case 2 from earlier on. And so for our patients, 8 out of 29 of them, so over a quarter of them, did come in at stage 4, none at stage 5, and then the rest at stage 2 and stage 3. And as far as our original treatment modality for our patients, so 7 out of the 29 of them were enucleated. These cases were all the stage 4 patients. And then a combination of other things were done at initial presentation, whether that was laser with cryo or intraarterial chemo, IV chemo, just a wide range of different treatment modalities. The most important thing, though, is that for our patients, kind of consistent with high-income level countries from the Global Retinoblastoma Study Group, 0% extraocular metastasis, 0% mortality rate. And so just some take-home points. So retinoblastoma can present in a variety of ways. There doesn't necessarily need to be a family history for there to be a germline mutation. It can come as a somatic mutation with unilateral presentation and come on as a bilateral presentation that has no family history. It really just varies. Globally, as we can see, that high income level or income level tends to dictate the outcome of these patients. At the Moran, we've seen 29 patients since 2017, including 7 new ones in the last year. And the most important point is, we have great outcomes, 100% survival, 0% of metastasis, very much in line with other high-income level countries around the globe. I just want to thank Dr. Hansen for the opportunity to get involved in this project. Thank you so much.
Just a short housekeeping notice. After the next presentation, we will have our morning break, and then we will resume at 10:30. But now our next presenter, Sam Wilkinson, who actually once swam with humpback whales over the Tonga Trench. Sounds very exciting. He will talk today about the comparison of modern IOL power calculation formula accuracy in post-penetrating keratoplasty eyes.
All right, thank you so much, Dr. Fleckenstein. And we did survive the whale encounter. We had a surprise visit from what I could have sworn was a great white shark, but the guide said it was a reef shark. Jury's still out. So today I'm going to be talking about modern IOL power calculation accuracy in post-penetrating keratoplasty eyes. And I do not have any financial disclosures. So I want to talk about the importance of this project. There's actually minimal research on IOL power calculation in post-PK eyes, although third and fourth generation IOL power calculations have been recommended, as well as ray tracings. Most of the literature is actually on triple procedure or endothelial keratoplasty. This study investigates the accuracy of the third and fourth generation IOL power calculations. Comparing the formulas will hopefully better inform planning and counseling for our post-PK patients. We'll start with a little bit of background on PK. So penetrating keratoplasty, or PK, is the surgical replacement of a diseased cornea with a donor's cornea. The first PK was actually performed in 1905. Different corneal diseases confer varying levels of success rates. The diseases that tend to have higher success rates include keratoconus, Fuchs dystrophy, corneal dystrophies, pseudophakic bullous keratopathy, and aphakic bullous keratopathy. According to data from the U.S. Eye Bank Association of America, there are about 17,000 PKs performed in 2023. For patients undergoing PK who also have a cataract, there's something called a triple procedure, which involves performing the PK, removing the cataract, and inserting an IOL. The first triple procedure was performed in the 70s, and the benefits include shorter visual rehabilitation and less effort for the patient. Many PK patients are too young and haven't developed cataracts yet, and there are also some refractive advantages to doing a sequential approach. For example, PK tends to induce a high amount of astigmatism, and so being able to address that with a toric lens later on can be beneficial. When preparing for cataract surgery in a post-PK patient, it's difficult to determine which power of lens to select. There's very little literature on the IOL calculation accuracy for post-PK patients. Taking a quick step back to talk about IOL power calculation formulas, the first IOL was implanted by Harold Ridley in 1949, and surgeons quickly realized that IOL power calculations would be necessary. In the 1980s, the SRK formula was created based on two of the most influential factors, the axial length and keratometry. Unfortunately, we've had a lot of advancements since then. The nuance of the various IOL power calculation formulas is beyond the scope of this presentation, but I want to give just kind of a brief overview. The first generation is represented by SRK from 1980. The formula is seen here and includes, maybe you can't see my mouse. The formula is seen up there. It involves three different variables. There's the axial length, keratometry, and then the lens A constant. The second generation of formulas includes the SRK2, the Hoffer's adjustment, modified Binkhurst formula, and this generation attempts to increase accuracy for very short and very long eyes. The third generation includes the Holiday 1, SRKT, and Hoffer Q. These formulas try to mathematically correlate the anterior chamber depth with axial length. And finally, fourth generation formulas are introducing AI and big data. So methods for our study, we conducted a retrospective analysis of 13 eyes with a history of prior PK. The patients came from a single surgeon. Each patient had uncomplicated cataract surgery. The patients included 4 women and 7 men with ages 42 to 72 years old, and the average age was 60. The time since PK varied from as recent as 7 months, and one patient that was over 21 years. All the patients received either the Bausch & Lomb MX60E or J&J ZCBU. Most of the patients had a history of keratoconus, but there was also patients with post-LASIK ectasia, ocular graft versus host disease, and limbal stem cell deficiency. We obtained refraction at the post-op month 1 visit. We then used the ESCRS IOL calculator to retrospectively look at Barrett Universal 2, Barrett True K, Cook K6, EVO, Hill RBF, Hoffer QST, Kane, and Pearl DGS. We calculated the prediction error and mean absolute error. We also looked at the proportion of eyes within a quarter diopter, half diopter, and 3/4 diopter of the formula based on the implanted IOL. and then we used McNemar statistical analysis. So let's move on to our results. So here are the ranges and averages for biometry collected for the patients. Notably, post-PK patients, especially those with ectasia, have an increased anterior chamber depth. In the general population, average anterior chamber depth is 2.5 to 4 millimeters. Our cohort had 4 patients with anterior chamber depth greater than 4 millimeters, and the average was about 3.5. As expected, the K values and delta K were highly variable. Many of these patients had steep corneas with high astigmatism. Typical K values range from 41 to 47, while our group had K values ranging from 39 to 57. 7 of the eyes had a steep K greater than 47. Additionally, axial length ranged from 22 to 28. Only 5 eyes were within the normal range of 23 to 25 millimeters. Here are the results of the 8 different formulas. The mean absolute error ranged from 0.83 to 1.0, and most of the formulas had about half of the eyes within a half diopter. Attention is drawn to Cook K6, which had the lowest mean absolute error at 0.83 and the highest proportion of eyes within a quarter diopter. The Cook K6 had 42% of eyes within a quarter diopter, which was significantly higher than the Barrett True K and Barrett Universal 2. Most of the IOL formulas tested had similarly high mean absolute error, but there was actually no statistically significant difference between Cook K6, EVO, Hill RBF, Hoffer QST, Kane, or Pearl DGS. I wanted to show this chart to demonstrate how comparable the 8 formulas were in respect to the proportion of eyes within each range. Cook K6 is the light blue, which is the third one from the right, for the one from the left. At the post-op month 1 visit, manifest refraction showed a cylinder ranging from 0 to 6 diopters with an average of 1.4 diopters. The uncorrected visual acuity ranged from 20/25 to count fingers. Unfortunately, we did not have uncorrected visual acuity on all the eyes, but 4 out of the 9 eyes that we did have data on were 20/30 or better. And we had best corrected visual acuity for all of the eyes, which ranged from 20/20 to count fingers. And 8 out of the 13 eyes were 20/30 or better. The Cook K6 provides good IOL power calculation accuracy for sequential cataract extraction after PK. The EVO, Hill RBF, Hoffer QST, Kane, and Pearl DGS were non-inferior. Despite improvements in IOL calculations, post-PK eyes are still expected to have high variability, and patients should be counseled on high variability prior to cataract surgery. The preoperative and postoperative refractions can add to the high variability. In our study, we had the same individual performing all of the refractions. The consistency with refraction is really helpful for research purposes, for patient outcomes, as well as personal data tracking. Performing cataract surgery on a post-PK patient is not very common, but some of these findings may be applicable to patients with a history of refractive surgery who have similarly high variability in IOL power calculation accuracy. The limitations of our study include that it was a small sample size, a single center, and a single surgeon. Some of the formulas included exclusion criteria, so not all patients were able to be run through every formula. For example, the Cook K6 actually limits the K values to 32 diopters to 57 diopters, which meaning one of our patients who had the highest steep K was actually excluded from this formula, and that could have potentially skewed the mean absolute error. It didn't, however, affect the number of patients within a quarter diopter of target. And then 3 eyes actually still had PK sutures, which will likely affect their cylinder down the road. In the future, we'd like to add to the sample size of post-PK patients. We'd also like to evaluate how many of these patients have returned to using scleral contact lenses. One of the factors contributing to variability in post-PK patients is posterior corneal curvature. And we didn't collect this for this study, but that would be an interesting factor to look into at future surgeries or future studies. And a huge thank you to Dr. Mifflin, Dr. Savage, and Dr. Azar for help with this project. We're presenting it at a poster next week at ARVO. And